is Dr. Mathew Leonardi. I'm a gynecologic surgeon and ultrasound specialist. I work out of McMaster University Medical Center, and there I have a very large team that works on patients who have endometriosis and persistent pelvic pain. Within gynecology, a large number of people suffer from this enigmatic disease of endometriosis, a disease that causes tremendous pain and decreasing quality of life, and for some, fertility-related issues. And there's a large group of people in society that have this, primarily cisgendered women, but gender diverse individuals, trans men can also suffer from endometriosis. And we have an incredible clinic at McMaster University Medical Center, which is not just myself, but a team of individuals who help these individuals with persistent pain and their endometriosis through medications, through surgery, and through complementary and alternative strategies. There are so many incredible areas of exploration that are happening in the world of endometriosis and the larger world of gynecology. And for me, that's part of the inspiration, is to keep learning, see what's happening around the corner, but more than that, be one of the people who's leading in this space, really driving forward that agenda with respect to the diagnostic dilemma. Why are people waiting 5 years, 10 years, 20 years to get diagnosed? Why are diagnostic tests insufficient? Why are our treatments so limited in that people don't have the options to get better? They fail medical treatments and surgical treatments. The number of mysteries, the number of, therefore, solutions that are available for me is inspirational. I am working with a number of academics within the Hamilton Health Sciences ecosystem, within the McMaster University ecosystem, and beyond, through Canada and across the world, to help solve these mysteries. One of the biggest areas that we're working on is what we call phenotyping of a patient, of an individual patient. We all know that every single person is unique, is different, but in medicine we have traditionally categorized people and tried to apply treatments to them under a larger umbrella, rather than what we might call precision medicine or individualized care. So a big part of our research program right now is looking at the unique features that an individual person has and how to refine the treatments that they receive based on that very unique recipe. And so a big part of our phenotyping that we're working on right now is around the imaging, the ultrasound appearance of endometriosis, which is a disease that has multiple phases. It could be a very small lesion of a millimeter in size to a severity where the entire pelvis is stuck with adhesions. The organs are kind of glued together, and anywhere in between those. Honestly, I think within our hospital system, we have the best diagnostic ultrasound team in the whole continent. And I know that might come off as a little bit egotistical, but we truly have people coming to learn from us from all over the whole globe. We have people, of course, local trainees who are coming to learn from us how to use advanced ultrasound techniques and principles to help diagnose patients with endometriosis. But we have people literally coming from America, from Europe, from Australasia to learn from us. And I think we are the leading center in the whole country when it comes to the diagnostic approach to endometriosis, both from the imaging perspective, but our foresight into that world of precision medicine, mapping not just what the disease looks like, but who is the person that has this disease and what are their various comorbidities, their goals. That, I think, is where we're leading. I think it's really important to first say that in society, we don't see as much financial support for gynecologic related matters. There is a history of funding things that affect men more than affect women. And there is disproportionate amount of resources from granting organizations that have gone to diseases that have the exact same prevalence as endometriosis, like diabetes, or diseases that have a lower prevalence than endometriosis, like inflammatory bowel disease. And that's not to diminish at all the importance or value of funding those other diseases, but they exist either in a higher absolute number or in an equal relative number to those other diseases. We have not seen funding come through for women and individuals who are affected by endometriosis. And that funding at this point, because we have yet to see very much of it, could really be applied to so many places. But I would say within the HHS ecosystem, what we struggle with is space. We do not feel like there is sufficient and adequate space for growth in our gynecology department to devote towards endometriosis. With respect to the rooms that we have access to in the hospital, with respect to the operating room time, we really do need more access to resources within the hospital system. And then of course, there's always room for research funding. That is something that will always be part of my career. Every single patient that walks through the door is a potential candidate participant for a research study or multiple research studies. And so we have probably, I would estimate, somewhere between 40 and 60 ongoing research studies right now. You have tremendous potential to enhance the quality of life of people who are suffering, often from teenage years without answers, without awareness of what's happening in their body. And the number of years of uncertainty and anxiety that goes into a health issue without answers has very severe long-term impacts on them, on their mental health, on their family, on their potential to reach their career goals, on society as a whole. We have such tremendous potential if donors are willing to support endometriosis as a disease entity to answer some of these questions, get the solutions, and hopefully be able to catch the disease early, get the treatments correct early, and allow people to flourish, whether that's their professional life or their personal life.